Hola Barcelona, and welcome to English Radio Barcelona Blue on La Marina Cat 102.5 FM. I'm Virgil, still and always. Well, prostate cancer is often described as one disease, yet outcomes can differ dramatically depending upon biology, genetics, access to care, and even geography. Joining us today, we welcome Dr. Elisabeth Heath, Chair of the Department of Oncology and Chair of the Division of Oncology Research at the Mayo Clinic in Rochester, to help us understand more about the disease. Welcome to the show, Dr. Heath.
Thank you for having me.
Well, I'm glad you could make it, with everything that's happening with your travel plans. We're glad you could adjust it and be here. Well, firstly, for listeners who are unfamiliar with the complexity of prostate cancer, what are the most important biological factors that can influence whether a cancer becomes aggressive or remains relatively slow growing?
Yeah, such a great question. I think the biggest factors are tumors genetics. That's sort of how the cells look underneath the microscope. It's a term we often use as grade. It really kind of showcases how the cancer is interacting with hormones like testosterone that really sort of fuels the prostate cancer. Some prostate cancer have changes that drive rapid growth, while others grow really slowly and never cause any harm. So it's a little tricky, but it's a combination of the tumor's biology and the environment that really, I think, ultimately determines how aggressive it will be.
What you're saying is that there's more than one kind of prostate cancer in some ways.
Yeah, I think what we've learned is it's a really complex scenario, which kind of makes sense for a cancer that's, number one in men. It's really sort of an interaction of many different things. But what we learned recently is how important the role of genetics is and sort of what molecular factors are driving a lot of the cancer.
Well, I think it's important because it kind of leads into my next question is that now you've done a lot of research on various populations about aggressive disease. What have we learned about the interaction between genetics, environment, and social determinants of health?
Yeah, I think it's always an interplay, I think, of those three. I mean, obviously, there are more things that can impact that, but um, how they sort of layer in together will really depend on which part of, their journey they're on, what they've experienced, and um, I think it really can depend on many factors. I think an important factor is just even having access to care and stress of what's happening in your life and when are you really diagnosed. Ultimately, all of that influences how your outcome will eventually be. So, very complex interplay of many things.
Well, what role do lifestyle factors play, such as diet, exercise, stress, cardiovascular health, play in long-term prostate cancer outcomes?
Yeah, they play a meaningful role, I think, especially over the long term. Cardiovascular health, physical activity, maintaining a healthy weight, they all can influence cancer outcomes and survival. I think stress and diet matter a lot too. They can affect inflammation in the body, hormone levels. Um, Importantly, what we hope is that each man that has prostate cancer live a long time. So these lifestyle factors become just as important as the cancer itself in shaping long-term health.
Now, you mentioned access to care, and probably one of the biggest things we've seen is that as men, we tend to not think about our health, even though we might have access to it, to great health care, insurance coverage, whatever, we don't do it for a variety of reasons, you know. How much does the delayed diagnosis contribute to the poor outcomes in prostate cancer today?
Yeah, it definitely still plays a significant role. When prostate cancer is just found at a later stage, for example, if it's spread or just becomes so aggressive and out of the actual prostate area itself, it's really hard to treat effectively. And we do, even in 2026, see delays. It could be access to care. It could be still a lack of awareness or even just the thought that this is something that can affect you. I think sometimes cancer feels like it's something that can happen to other people, but not really to yourself. So timing matters. I think catching cancer early, being able to diagnose it, is really important.
We'll be back to talk more with Dr. Heath right after this. And that was Ori Kaplan with La Rouge. Now, one of the most important conversations in modern oncology is ensuring that advances in research benefit everyone, not only the populations traditionally represented in clinical trials. Now, historically understudied populations are often diagnosed later and experience worse outcomes. What barriers still exist today?
Well, a few big ones still persist. Here in the States, access still is a major issue. Many clinical trials are often run at large academic centers, and they're not often easy to reach. I think as you know, many of the cancer care that happens in your own backyard. And if the nearest cancer center that has the clinical trials is, 3 hours away, that still is a barrier. And then I think there's still topics where trust is an issue. If you're really not sure that those, the team or the physicians are in your own backyard, there's sort of a lack of awareness or even a history there in terms of, what is the intent of the clinical trial. So that takes time and that takes consistency to build. And then on top of that, as you and I've talked in the past, the eligibility criteria to get into a study can sometimes, even unintentionally, exclude patients. And those are typically, patients with other health conditions that are not sort of the classical prostate cancer is the only problem, and that's the only thing I'm studying. So it's never as simple as it is in a well-crafted clinical trial. So it's critical that as we learn um, just new knowledge of what's really happening, that it's available as an option. This is something that should be offered in terms of clinical trials for patients, and we continue to need to work at this actively.
I totally agree with that, as we know from our experiences together over the years. Now, why is it scientifically important to study diverse patient populations when we develop new therapies?
Because cancer isn't the same in every patient. Genetics, environment, and even how drugs are metabolized in different humans, it can differ across populations. So if you really don't study the diverse groups, I think we risk developing treatments that work well for some patients, but not for others. And we miss the chance to make therapy safer, more effective, and truly applicable to everyone.
Now, with that in mind, what have we learned about the biology of aggressive prostate cancers from these broader research efforts?
We learned that aggressive prostate cancer are biologically distinct. They're just not later versions of slower cancer. So there is this sort of perception that you start off slow, everyone starts off slow, and then at some point it picks up speed. I think we're starting to recognize maybe that's not the case. In certain cases, there are just genetic changes that are happening right up front, and they can impact, the process of prostate development, the cancer development, at times independently of testosterone or hormones. And these are the aggressive ones that can really worry us because they behave differently and they may need different treatment approaches.
Now, you've been a strong advocate for expanding access to clinical research. Why has representation in clinical trials become such an urgent issue in oncology? A lot of it has to do with what you said earlier in terms of understanding who we're making drugs for, but it seems like more and more now there's an urgency to move forward in this area.
Yeah, and gosh, Virgil, you and I talked about this because we understand that when we do studies, it really shapes kind of what we learn. And if you're thinking a certain way, but you're not thinking another way, there could be opportunities sort of left on the table where we don't really understand what is happening for every single person. So if these clinical trials don't reflect the patients we actually care for, we can't always be sure that the treatments will work the same way for everybody. And then in that, scenario, we may miss important differences, whether it's in benefits or even more worrisome in side effects. So representation for understanding who are the populations that we're serving, it's just essential to better care and good science.
Well, now you've been very active in this area in terms of being able to be certain that clinical trials are offered to as many people as possible. But how do you balance your cutting edge laboratory work with community engagement and patient advocacy?
They're just not separate in my mind. As you sort of learn from one aspect, it informs the other. So it's a two-way street. This understanding of the disease and the laboratory science, or even in a, more genomics, so what we call dry lab science, and the community engagement piece and patient advocacy, we all need to have this conversation at the same table, because often the community is the most important part of the well, not just representation, but the voice that tells us where the real gaps are and what patients actually need. Um, Making that connection in real time, sustained, it makes the research not only relevant, but I think more impactful. So conversations have to include everybody at the table.
Totally agree. We'd like to talk more with Dr. Heath right after this. And that was Aves with Can't Get Enough. The treatment landscape for advanced prostate cancer has changed dramatically in recent years, offering more hope to patients and families that weren't there before. What are the most exciting developments currently transforming advanced prostate cancer treatment?
One of the most exciting advances, I think, is in the world of precision medicine. That's how we think about having to match treatments to the biology of an individual prostate cancer patient's sort of makeup. We're seeing a lot of these progress with targeted therapies like PARP inhibitors, so many new trials, and I think more to come in terms of reporting of, advanced clinical trials that have completed, radioligand therapies that deliver radiation directly to the cancer cells. That world has exploded. It's really an active effort to try to keep up with what's happening in the clinical trial space there. And then just a variety of different and exciting combinations of hormonal therapy and immunologic therapies. That's now coming back, where I think even just years ago, we weren't sure what the role was of the immune system, and now we have better ways to try to engage that in prostate cancer. So it's just really encouraging that patients with advanced disease are living longer, and often with better quality than we could even offer a decade ago.
I know that this is amazing what we're seeing in terms of benefit to the patients. But now you've worked extensively on both single agent and combination therapies. Why are the combination approaches becoming increasingly important?
Prostate cancer is rarely driven by just one pathway. I think the last sort of 15, 20 years have really shown that. I think many cancers have been interrogated and investigated over the years with that idea. You know, you have one major pathway that's not right. We're going to develop a drug and we're going to come after it. But as our knowledge have grown in time, we recognize that boy, sometimes the prostate cancer or just cancer in general is a bit smarter and one step ahead. So we're learning that if we just target a single mechanism, yes, the cancer may slow in the beginning or even go quiet, but at some point it adapts. And combination therapy, sort of upfront, getting that more intensified approach, that usually will allow us to block multiple pathways at once. And I think there we can make the treatment more effective, but also really keep that state of response for a longer period of time. So delaying this resistant state. So that's what sort of combination therapy is telling us to do these days.
Now, it's important we look at it because, but again, we get back to the issue of precision medicine or targeted therapies. Really, we're saying that we have to tailor something to the patient. But how are we really able to determine what drug is going to be right for which patients? I mean, obviously, we're going to be looking at the genetics and all of that of the patient, but are we at a point where we can really now look at every patient and have had a genetic scan done to be able to identify what drug is going to be most effective for this particular person?
Yeah, I think we're much better at that. You know, even if you're, let's say we start with a patient that has presented just for the first time with metastatic or spread disease. You know, years ago, that literally was the beginning of the end. And the way we look at that now is that's just the beginning of the beginning. So we need to establish what's happening. How do you really know about the genetics? Well, we have to check it. It's an active process where we will make it now, which is now also standard of care, to check a person's what we call inherited genetics. And that just means sort of the DNA that has been passed down from, you know, one parent on one side and the other parent on the other side. And that's sort of what makes you you. And the technology now has allowed us to do that and also check what we call somatic testing, which is checking what the cancer is doing that has sort of taken that original DNA blueprint and gone rogue with it. So it's now become standard of care to look. Now, I mentioned PARP inhibitors earlier. You know, that's for men with what we call the breast cancer gene or BRCA2
Hmm.
mutation here in the States. So as we get much more fine tuned, many of the drugs that are being developed, and this is true for all cancers, but now really becoming true in prostate cancer, they have to come with some sort of a companion diagnostic. So we're not relying on everybody to know everything for every test, but there'll be some guidance on what type of test and what type of mutation should be checked, and then is that drug a right fit?
Now, again, the
So
ultimate question that many patients have is how close are we to making advanced prostate cancer a manageable chronic disease, much like hypertension or diabetes?
I think we're getting closer. I think we are closer now than we've ever been before, but we are not fully there. If you compare us to 10 years ago, lots and lots of progress. So now, for many patients, we can see control of this cancer, and when you're controlling it, it means that we're delaying the progression to what is known as a castration-resistant state. You know, that's when sort of blocking the hormones from driving this cancer doesn't really do the job wholly. So that period of time when you are still sensitive, it's such a meaningful time because your cancer is controlled. And then trying to reduce complications like skeletal related events. You know, those are things such as bone breaks or pain in the skeleton where you need radiation. So overall, we're doing better in preserving quality of life. I think more importantly, we're measuring tests at least to make sure that we're preserving quality of life. So now that has become an important part of any clinical trial that's moving forward. So lots of advancements, but we're not there yet. I think there's still so much more to happen in the next few years.
And it's going to happen when we have patients involved in the clinical trials.
Absolutely. 100%. It's every voice at the table, and each one will matter.
We're back to talk more with Dr. Keith right after this. And that was Avni Vibes with Evening Elegance. Now, you're going to be participating in a May 29th symposium in Chicago regarding continuing the innovation story in prostate cancer, which will examine many of the rapidly evolving areas in prostate oncology. The seminar is really targeted toward clinicians, physicians, radiologists, nurses, even patient advocates, anyone really involved in the area of prostate cancer research and care. What do you hope to be gained or learned in the symposium that you feel optimistic about?
There's so much going on now in prostate cancer that it is truly an exciting time. But it's also conversations like, the meeting that we're going to be a part of to continue this conversation in a manner that makes sense. There's so much information always coming at us that it is hard to know where to focus. As I mentioned earlier, I think the world of sort of genetically targeted treatments that's matched to a patient is starting to explode. PARP inhibitors are sort of one of those areas because it's the most mature. I think there will be additional data presented during the ASCO meeting in that regard. The radioligand therapy space, again, those are treatments that deliver precisely to the tumors, and oftentimes there is a companion imaging diagnostic, which is why these drugs are known as theranostics. There will be new areas and new targets being presented at the meeting. And then the whole world of sort of immune therapy. For many years, prostate cancer is thought to be, and is still perceived to be, what we call a cold tumor, where the traditional agents out there that just really haven't made the impact that we had hoped. But there's a whole new world known as bispecific therapies or T-cell engagers that kind of help the immune system directly recognize and attack prostate cancer cells, that area is also exploding. So many, many different new topics to talk about, but also the conversation is important because they're complex topics. So this is not something that you hear it once and it makes sense. I think it'll have multiple conversations to really understand the how. But the goals for all of this is to move forward with better endpoints, more precise, and hopefully less toxic agents for our patients.
Well, I think the whole thing that we look at in many cases that's been part of the problem in the past is the acceptance and adoption of new and emerging therapies. Uh, One of the things I look at in terms of evaluating a lot of the clinical trials that I've been part of is that oftentimes, as part of the study, there'd be the agent or the drug that's looking to be tested to see if it's efficacious and effective. And it'll be matched against a control drug, which could be something in the library already available to the patients of the world. And oftentimes left to the physician to decide, all right, what am I going to use that control drug, or what am I going to use in some cases to treat the patient? I think the thing is that concerns me is that how do we ensure that the adoption of knowledge is enhanced and the application of that knowledge is delivered to the patients effectively and efficiently and equitably across all sectors?
That's the question that I'm so glad that we continue to talk about because I think it begins with having conversations that there's still this gap. Um, we make advancements in one world where it's sort of, for the patient that has no major issues, that live right next to an academic center, that, qualify and have everything. And the gap in that person versus the next person, the next neighbor, the next state, the next country is astronomical. And I think here, where it's all up to us as a scientific community, and that includes the community at large and patient advocates, is to be able to ask questions in terms of how does the drug work? What were the side effects? How can I get it? How can I ensure that testing is done? As you and I know, for many years, and this continues to happen, a great publication comes out. We all agree this is the right answer. There's at times an FDA approval, and we're excited about it, but then it's not implemented. So where it falls off is at times it's the field of cancer, especially in prostate cancer, is moving so quickly, just trying to understand what is standard and then decide, is that control arm what you do in your own practice? That is why meetings like ASCO and ASCO GU and so many other meetings that occur during the year need to continue. Because what we're talking about today may not be so relevant even 6 months from now. So not only is the story complex, it's also ever changing, in my mind, for the better. But when you're just trying to keep up with the basics and also decide this is the right answer, it may be so for today, but not so 6 months, a year, 2 years from now. I really do commend a lot of investigators and companies and whoever is involved in studies, because it takes a long time to complete these studies, as you know.
Mm.
So a control arm that was right 8 years ago may not be the ideal control arm of today. So it's always trying to say, okay, well, that data says this, but what does it mean in today's landscape? And those are conversations that we all continue to have and ensure that we sort of interpret and be able to implement what it is in today's language, even though it was designed a little bit differently years ago. So lots of work still to be done.
No question about that. Now, one of the areas that's also of concern for me is the role of AI. We're seeing AI being used now to interpret radiological information. We're seeing AI being used to make comparisons in terms of drug control agents. We're seeing AI being used to help in diagnosis, but at the same time, we're seeing that AI is not, number one, available to everyone, and even to those that it is available to is being used inappropriately and incorrectly. So, I mean, where do you see AI occurring in this role of prostate cancer going forward?
Well, I think for one thing, certain AI isn't going anywhere. I think it is a new tool that, when, like any tool, used correctly, it's really helpful. There are already, as you know, diagnostics out there that is now incorporated into our national guidelines to be able to help predict, how much hormone a man gets, for example, with a high risk or very high risk disease. Um, that is in conjunction with their radiation. So when used right, I think AI, after it's sort of been proven and sort of vetted in a scientific way, makes sense. But AI is also just being used for a variety of things. I think we're all reliant on that for just everyday questions. Well, our community, I think, have really taken that, and there are now many, many companies that encourage you to upload your medical records so there could be some analysis done. AI is extremely helpful if you're an expert in your field and you say, wow, yeah, that's actually right. And they got that right answer very quickly. And you don't need someone like myself or someone like yourself sitting right next to them. But AI can often be wrong. So just like in any, if you were to search for any question, on the web, you have to know how to edit so some of these answers, some of these sponsored ads, for example, that pop up. So the answer isn't always right. And as you know, those are things known as hallucinations. And
Yes.
medicine, AI often hallucinates. And when you're not an expert in field, you're not sure if that is true or is that something made up? And that is a problem that I hope will go away as the actual field matures. But the potential for AI is tremendous. Why? Because it could make sense of just large, complex data sets. Imaging. We were talking about genomics, even just clinical knowledge. How you interpret your own practice. You just put that all together. It would take years for sort of a manual approach. AI using whether it's large language model or whatever the model that is sort of used can digest all this information and sort of spit that out. So I think it's not even just the decade. I think in just the next several years, this could really have a huge impact, whether it's earlier detection, better treatment algorithms. But as you and I have discussed, AI may tell you an answer. It may even be the right answer, but it's not responsible for implementing said answer. So
Right.
we've solved everything with AI, but it is an exciting tool that can help.
We'll be back with some closing comments right after this. And that was A Change for the Better by Gil Kita. I've said oftentimes that, in life you need to have a great lawyer and a great doctor. Now, since you fall into that category as a great doctor, as far as I'm concerned, where can listeners connect with you and learn more about what you're doing?
Well, first of all, thank you for your kind words. I am just so grateful to still be in this fight, honestly. And it is a fight because we have to fight for every patient diagnosed with prostate cancer. And sort of having conversations with you, Virgil, and so many others in the patient advocacy and community groups is vital. And I'm always really grateful to be able to continue to talk about such a common cancer that affects men, that can impact lives, that it's truly a privilege to be doing what I'm doing today.
Well, you do it very, very well. That's, the truth from that standpoint. Now, you talked about the idea we're moving more toward personalized care in prostate cancer. Now, from a practical standpoint, what should that look like for patients, and what should patients be doing to ensure that they're getting truly personalized care?
I think it's up to the patient to be as informed as possible when they're visiting with their healthcare provider, physician, or however that team is made up, because we know healthcare teams are also very different in the States and also outside of the United States. The number one question should be, is there a clinical trial that I qualify for? Because that's often the question that gets left to the last and deprioritized. So that's the first. I think the second would be, especially if you have high risk or advanced cancer, is there a genetic test for me? And I think just phrase simply to begin the conversation should alert, the physician or the provider to be able to have that discussion. It really does begin knowing what your genetics are that can help drive what are the next steps afterwards. That question alone is often missed, Virgil, as you know.
Mm,
So we
yeah.
worry about here's the treatment and we're doing a better job of explaining here's some of the side effects that can happen, but those top two questions are often an afterthought. It gets maybe sent as a note afterwards in the portal if you're lucky to have a portal, but most of the time it doesn't even get talked about. So this is a fight where we all have to be in it together, and sometimes in a busy practice, it doesn't get brought up. So we have to make this a team effort. So if the patient or the family member will say, is there a clinical trial for me or my loved one? And is there a genetic test that I should be getting? That's already halfway there to being able to elevate your care.
Well, I think one of the things we're going to talk about too is that we've talked about the situations where the diagnosis has been made, maybe a treatment has been made, but going back a step further, how do we know when we're at high risk of having prostate cancer?
That is also complex. As you know, it begins in so many different ways. In the community, many people don't, unless they have some symptoms, don't have a urologist or a medical oncologist or radiation. We're sort of the next step after the problem's diagnosed. So we're reliant on conversations and guidelines with our primary care colleagues, that's internal medicine, family medicine, and it begins with still the tried and true PSA screen and a digital rectal exam. We're getting that word, I think, out more and more these days, but it's still not 100%. I think community events are critical to be able to just raise awareness. Many people are aware about blood pressure and hypertension or even diabetes. And if you're on social media, there are many, many influencers, for example, that will sort of talk about just wellness in general. But prostate cancer is still a tough topic to broach. It talks about symptoms that, no man really wants to talk about. So
Right.
we really need to encourage just sharing what is happening and to ensure that you are not alone in feeling this. This is the number one cancer in men. There's lots of men in that same arena that may have these symptoms. So talk about it. Ask your doctor.
Now, if you could leave patients and families with one message of hope about prostate cancer care today, what would it be?
Boy, I am so grateful that there is real reason for hope. Um, when prostate cancer is diagnosed early, the chances of cure remain really high. And even if it's more advanced upon diagnosis, we have so many more effective treatments that can help a prostate cancer patient live longer and live well. And importantly, progress is continuing. I think that's the good news, if not the great news. It really gives us more reason for optimism now than even 5 years ago. There is real hope out there, and we must continue the fight.
Well, those are very good words. And we want to thank you, Dr. Heath, for joining us today and being such a great guest.
Thank you so much for having me, Virgil. I look forward to seeing you soon.
Very soon, very soon in Chicago. Thanks a lot. This has been Barcelona Blues Voices. It's been a great one, very educational, informational, and we're going to leave you today with a song by Amos Ayres Hadani called Dreaming of a Song. Have a great day, Barcelona, and we'll see you next week.